Good morning, honorable members of the Pharmaceutical Society of Kenya, our guests from other cadres, our distinguished speakers and moderators this morning. Ladies and gentlemen, my name is Daniela Munene, and I'm the CEO of the Pharmaceutical Society of Kenya, and I'm your host as usual for this edition of Pharmacy COVID-19 Dialogues that we hold every Wednesday morning, where pharmacists share what they're doing to respond to the COVID-19 pandemic. So allow me to introduce you to our moderators for today, who will take you through the program. Next slide, please. Our moderators are Dr. Michael Mungoma, who's a member of PSK. He's also the Dean of the School of Pharmacy at MKU, that is Mount Kenya University in Thika, and he's a member of the PSK National Executive Committee of the National Governing Council, and he's a member of the PSK COVID-19 Response Task Force. Welcome very much to this webinar, Dr. Mike Mungoma. Please say hello.
Good morning, everyone. I'm happy to be here.
Karibu sana. Our next moderator is Dr. Sylvia Opanga. She's a member of PSK, an active member, I might add, and she's a senior lecturer at the School of Pharmacy at the University of Nairobi. And she's also the chair of the Education and Public Health Committee of PSK COVID-19 Response Task Force. So please say hello to our participant, Sylvia, and I'll hand the meeting over to you. Thank you.
Good morning, everyone, and welcome. Thanks for coming in. We are looking forward to an excellent presentation. So today we have Professor Godman and Dr. Manj. Before we start, we'll have a few ground rules and announcements. So you will all be muted during the entire course of the webinar. Please ask questions via the Q&A tab at the bottom of your window. Do not direct your questions via the chat tab. Those questions will be addressed by the panelists later in the program. For PSK members, if you've not already done so, please subscribe on the PPD portal for today's webinar so that you can get your CPD points. For PSK members, kindly note that CPDs will be awarded to paid-up members only. This webinar is being recorded and the audio will be made available on PSK's YouTube page. So I'll go ahead and introduce our speakers. Our first speaker is Dr. Amanj Kugi. He's a lecturer in Pharmacoepidemiology and pharmacy practice with interest in drug utilization research around non-communicable diseases and infectious diseases, focusing on promoting rational use of medicines, as well as adherence or persistent to medication using secondary database analysis and patient-level data through applying various statistical and analytical techniques. He's also interested in health service research, including the evaluation of the impact of the health policies and clinical guidelines. He's currently a lecturer in Pharmacoepidemiology and pharmacy practice at Strathclyde Institute of Pharmacy and Biomedical Science, University of Strathclyde, Glasgow in Scotland. Dr. Manj holds an MSc in clinical pharmacy from the University of Baghdad and a PhD in pharmacy from the University of Nottingham, UK. I've worked with Manj a lot and he's also a good friend. So welcome, Dr. Manj.
Thank you, Sylvia.
I will introduce our next speaker, Dr. Brian Godman. Since 2006, Dr. Brian Godman has worked with governments, health authorities, physicians, and pharmacists across countries and continents to enhance the quality and efficiency of prescribing. This has resulted in over 300 publications in peer-reviewed journals. In 2015, Brian helped form a Pan-African drug utilization group called MURIA, which stands for Medicine Utilization and Research in Africa, resulting in over 100 publications to date, covering both infectious and non-infectious diseases, including COVID-19. Brian will use these combined experiences to discuss pharmacoepidemiology and drug utilization in the era of COVID-19, including assessing the unintended consequences of COVID-19 on other infectious diseases or non-communicable diseases. He's an honorary researcher at the Division of Clinical Pharmacology, Karolinska Institute, Huddinge University Hospital in Stockholm, Sweden, a visiting professor at Strathclyde Institute of Pharmacy and Biomedical Sciences, University of Strathclyde, Glasgow in the UK, and Pharmaco University in South Africa. He's also one of our main collaborators at the University of Nairobi, and a good friend of mine as well. So welcome once again, Brian.
Hi, thank you. Good morning, everyone.
So for the agenda, we'll start with Dr. Amanj, who will introduce pharmacoepidemiology and drug utilization in the era of COVID-19. Then we'll move to Dr. Brian, who will talk about what we've done together in Africa. And then from 12:10, we'll have the Q&A session moderated by Mike. So I'll move on to Amanj.
Okay, so first of all, good morning, everyone. And I would like to thank Sylvia and PSK for the invitation to be involved in this webinar. I'm very delighted. So I'm just going to share my screen. Okay, so I will try to talk about some definition and taxonomy around pharmacoepidemiology and drug utilization research, and then we'll introduce kind of roughly the study designs that we have in pharmacoepi studies, and end with things that we need to consider or think about when we want to do any kind of pharmacoepi studies in COVID-19 pandemics. And I will give an example on the effect of using of ACE inhibitors and ARBs on COVID-19 clinical outcomes, and how those considerations would impact the result finding and conclusion. So in terms of definition, just a quick reminder for everyone. So we have some subtle differences between different terminology. So it's quite important that everyone knows the merit and the kind of the advantage and of each of those fields. So we have the epidemiology, which is the study in the distribution and determinant of disease in a population. And then we have a clinical pharmacology, which is, as you can see from the figure, is studying the effect of drugs in humans, but actually in a controlled environment. And then finally, we have the pharmacoepidemiology, which dealing with studying the effect and the use of drugs in a larger population, using a population-based approaches. So as you can see, each of these fields of research are quite related, but there are subtle differences, and it's quite important to know those differences. So if we look at the prescribing process of when a patient goes to see a doctor and then the doctor prescribe and then this prescription get to be dispensed and the patient needs to take that medications to have an outcome. That's where we have another kind of terminology, which is drug utilization research, which actually it deals with all the processes of the drug utilization process. So it deals with describing and analyzing the quantification, understanding, and evaluation of each individual step of the drug utilization process. That's the process of prescribing, dispensing, and the consumption of medication by patients, including adherence and persistence, but also extend to look at also test the effect of healthcare intervention to enhance the quality of these individual processes. So drug utilization is more kind of an umbrella term to include a variety of research and agenda. Another set of terminologies that's important to recognize is the differences between efficacy, effectiveness, and efficiency, because usually people get confused about the differences between them. So efficacy, when we say efficacy, is we're answering the question, does the drug work in clinical practice? So we're studying the effect of drug in a clinical controlled environment. And that's where we have, for example, in clinical pharmacology, doing RCT in laboratories, etc. While if we say effectiveness, that's indication that we are talking about real world data, that we are talking about the effect of the drug in real practice. Does the drug work in real life, in real practice, using secondary database? And then we have efficiency, which actually add the dimension of is that drug is a good value for money. So we have a dimension of cost coming into when we talk about efficiency. And within the, as you can see from the pharmacoepidemiology, that effect or use of drug includes pharmacovigilance, studying the side effects or adverse drug reaction of medication using real lab data. We have includes patient outcomes, includes some even pharmacoeconomics, also HTA process. So you can see that all these areas include using of population real world data. So if we just remind ourselves of types of study designs. So we have descriptive study designs and we have analytic explanatory, which looks to see if there's an association or any causality between an exposure and an outcome. And under the descriptive, we only describe the disease distribution or the exposure distribution. This is most cases will be more like a cross-sectional studies and case series reports. While for the analytical one, we have observational and experimental, which is interventional studies. And under observationals, we have cohort studies, we have case control studies. And pharmacoepidemiological or epidemiological studies actually include both kind of observational and cross-sectional, which also considered as an observational studies. So today I'm going to focus on this part and talk about some consideration that as a pharmacoepidemiologist or the pharmacists or the researchers that we need to consider when we want to do a research looking at the effect of a drug in the area of COVID-19. Of course, for any research, we use secondary databases, mostly that's more relevant to kind of developed countries. So usually we have, we need to collect data on the exposure. And as a pharmacist, we are almost interested in medicine. So, and usually we get that information from pharmacy dispensing and drug registries. So we get information around the name of the drug, the strength, the dose, the date of prescriptions, and so on. But then we want to link to see if there's association between this drug exposure and an outcome. And usually the outcome we get the outcome data from hospital data or from primary care visit to GP primary set, and that include diagnosis, procedures, lab results, and death things. But also equally important is that in pharmacoepidemiology, for some reason that I will mention later, that we need to collect data on confounders and effect modifiers, and usually we collect that data from either hospital record or GP data set, and that includes patient demographics, comorbidities, smoking, ethnicity, and so on. And in ideal world, usually we have a unique patient identifier where we link those data together to have a complete picture on the patient journey from the time the patient visits, see the GP, to the time he dispense the medication and consume that medication. But from our experience with Africa, this is usually a challenge in Africa because there is lack of electronic prescribing and electronic health records. So still in Africa, we rely mostly on primary data collection using a cross-sectional survey or looking at patient files or patient records in a paper format, which are time consuming. But I think now for COVID, we are almost doing the same now because some of the data that we need for COVID in our research that are not currently or readily available in even our data sets. So it's quite important to have a understanding of those data and what are you collecting. So in any research findings, when you read any paper or any research finding, about association between a drug exposure and outcome, we have three options. Either that result is the truth, there's actual association, or the results could be due to chance, or it can be due to bias or confounders. And usually we, as a researchers in pharmacoepidemiology, we do our best to exclude chance by having enough sample size, and then also reduce bias and confounder as much as possible. And usually, ideally, we do that by doing randomization and blinding. So if we exclude chance and bias, we left with the only option that's the observed association is likely to be truth. We cannot be certain, because we are not studying the whole population. We are taking a sample from the population, so we cannot be certain that this is the truth. But by excluding chance and confounders, we are likely saying, okay, the observed association will be a true association. And this will lead me to, I'm sure most of you have seen this pyramid hierarchy of evidence. So you can see at the bottom, we have case scenarios or opinions. These kind of are low quality of evidence and high risk of, and as we go to the top of the pyramid, we have high quality evidence and low risk of bias. And the reason why systematic reviews are the gold standard of the highest quality is because in RCTs, by doing randomization and blinding, we exclude bias and confounding. If you think of the triangle, and by even having enough sample size, we also control for chance. So it's likely that any results that we see in RCT is, if it is conducted, well, it's be a true association. While for, if we come from observational studies, which is the cohort studies and case controls, we can control for the chance by having enough sample size. But the issue is, sometimes it's quite hard to exclude 100% the confounders and bias. That's why it comes after RCT in terms of hierarchy of evidence. So now I would like to talk about some challenges or some consideration that we, as a researchers, we need to think of when we do a study around COVID-19. So the first of all is that do we actually need, what was the value of pharmacoepidemiology in the era of COVID-19, and how that is compared to experimental or RCT trials. So we all know that, for efficacy, usually RCT are the gold standard, okay? So we usually don't do a pharmacoepi study to look at the efficacy, to see if this a new drug is effective in treating COVID-19, because this is usually is the merit of that should be done using an RCT trial, a clinical trial. So, but having said that, pharmacoepidemiology, I think it's been important to look at the effect of concomitant use of medications and COVID-19 outcomes. And you're all aware that there have been a lot of studies of looking around the harm of using ibuprofen and NSAIDs, and that use of ACE inhibitor ARBs, they are harmful, leading to worse prognosis in COVID-19, but also about hydroxychloroquine that might be beneficial. And you all seen that studies in this area, they are all providing conflicting results. Some studies are positive, some no association, some found protective effect. And this is all goes back to some point that I will mention later on. So in the era of COVID-19, and also the other thing is to mention is, there is no point to have a study looking at a question about efficacy, which is another clinical trial is now undergo to try and answer that questions, because it is unlikely that a finding from pharmacoepi studies around efficacy will change clinical decision making. It is important, however, in, for example, generate hypotheses around potential new drugs for treating COVID-19, but to be sure that this, to look at efficacy, we need to do RCTs. So we need to be careful around what kind of questions we need to answer using pharmacoepi studies. The other thing, again, another challenge is around the design, okay? So usually the reason why most of the studies around looking at ACE inhibitors or IRBs and COVID-19 outcomes is we need to be careful around the population source, where did that study patients come from. So for example, studies which include only hospital patients, okay, cannot be, the result from that study cannot be generalized to wider population, because as you all know, hospitalized patients usually are severe, suffering from severe or more severe COVID diseases. So they are already at risk of death and other adverse outcomes and poor prognosis. So we cannot generalize the findings from hospitalized patients to cases from the community. And the other thing is, for example, if your cohort definition is include only patient who has tested positive for COVID-19, you cannot compare that with another study which actually used clinical symptom as a diagnosis, because that's again will lead to some misclassification in your cohort, and that will introduce bias and into the studies. The other thing is the use of active comparators and dealing with the issue of confounding by indication. And this is really important in the case of ACE inhibitors and IRBs, especially because so what do you mean by confounding by indication? So that's mean if the indication of using these drugs, which in this case will be cardiovascular disease, they are actually risk factors for outcome, which is death or poor prognosis. And we know from other studies that actually cardiovascular diseases, they are independent risk factors for poor prognosis in patients. So it's quite important that we control for that confounding by indication by comparing ACE inhibitors not against non-use or placebo group, but actually against other antihypertensive drugs, because at least you will use the active user or user design pharmacoepi, so you control in some way by the confounding by indication. Another challenge is with these type of study is the availability of data. Usually we don't have, even in our country, in the UK, we don't have data on, for example, on self-medication for pain, or even in your country using hydroxychloroquine as as a protection. And also the type of data availability will determine what kind of research question that we can answer. So for example, if we are interested to see looking at the risk of COVID infection as an outcome, then we need information, for example, around the travel history, contact with other patients, and usually those data that are not available in our electronic record. So if we want to do research in those areas, we need to carefully design a data collection form and using medical charts and have all the information very carefully. Other important confounder is the frailty and of the patient. So using frailty score, which has been shown in this as a strong confounder. So I think in the area of COVID-19 here, even in the UK, we now, it helped to accelerate some of the data set which we did not have before. So for example, GP data, usually we didn't have GP data, now it's coming on. Again, the hospital prescribing in a hospital is also another challenge, because that's also determine the outcome. The other aspect or challenge is how we define the outcome definition, okay? And this is especially if we look doing a systematic review of, or if we want to compare findings between the studies from different countries. We know that there is a temporal and geographical variation in threshold of testing. Okay, so every country, every region have different criteria to be eligible to be tested for COVID-19. And if we compare studies from countries with different threshold of testing, then you will introduce bias into your, or selection bias into your study, because in some countries, if the criteria is less strict, you would have less ill patient testing positive, and that can be in your study population. While other criteria in other countries with high cases and low resources, you may have very strict, and you only do test for very severe ill patients. So the disease severity actually will be a very strong confounder in this case. Also, the threshold for hospital, for admitting a patient to a hospital or to ICU admission is quite different between countries. And when you look at, you want to compare studies that effect of ACE inhibitors on hospitalization or ICU admission, and you see that studies across different countries sometimes are conflicting results. Something show beneficial effect, some shows harmful effect. And that may be just because the outcome definition in those settings are different. They are using different criteria for admitting a patient to ICU than in the other setting. So it's quite important to restrict, if you do that kind of cross-national comparison studies, to control for the places and the time where the test or the study is being done. And I will use an example to demonstrate or illustrate the effect of those factors that I've mentioned on how we interpret the finding from results. So in this systematic review that has been published looking at the effect of using ACE inhibitor and IRBs on the severity and the mortality in COVID-19 patients. So in the top graph, you would see that, we have 3 studies and actually 3 studies. We have 3 studies, and you can see the blue dots, they are, we have 4 studies actually. 2 of them showing, you can see they are showing protective effect, while the other 2, they are showing no benefits. And the pooled estimate, when bring all together, there is no association, significant association between using this medication and severity. The bottom one is actually looking at mortality, and here we have about 6 or 7 studies. Again, you can see the individual studies, they are floating all over the line. Some of them protective, others harmful, others no effect, but the overall estimate is, again, no significant association between use of these medications and mortality. So here in this study, they combined all studies together without taking into consideration, for example, as I said, geographical variation between how different studies used different criteria for admission and mortality. So what I did, and this is work that I've done with Brian and is currently under review, is I also looked at, for example, ICU admission to hospitals. Okay, if you look at all the studies together, again, you will see there is no significant association between ACE inhibitor, IRBs, and ICU admission. But once you do subgroup analysis by looking at the different countries, places, you have Europe, Asia, and the USA, you actually there are different results. So you can see that for studies conducted in the US, actually using this medication increased the risk of ICU admission. Okay, while from European studies, actually use of this medication are protective, is less likely to have ICU admission. And some of that explanation is just because might be, these countries or these geographical areas have different criteria for ICU admission. And again, when you subgroup analysis based on the quality of the studies, because I found that majority of the studies are of poor quality. Okay, so in this study that I've done, we had 27 studies. 21 of them actually did not do any adjusted analysis. They only have crude odds ratio, crude analysis. They have not made any adjustment for any confounders. And it's also a striking, finding, because usually it's unlikely that you will see a research being published if they don't have done any proper analysis. But because of the COVID-19, you will see people actually now getting away and get their study published, even if it is of poor quality and the analysis is not done properly. Another example is if we look at hospitalization. Again, if you combine all the studies together, you would see that actually there is no association. But once we do subgroup analysis to look at the different geographical location, again, you would see, for example, studies from the USA actually using this medication increase your risk of hospitalization. And again, if we look at the quality, you see that the poor quality studies, there is no association, while the good quality studies, there are association. And again, if we look at studies based on whether they have used crude analysis or adjusted analysis, you would see no association among studies which only used crude analysis, but actually there is a association between using this medication and high risk of hospitalization among good quality and studies which adjusted for confounders. So in conclusion, you can see that we need a good high quality designed pharmacoepi studies to generate hypothesis. okay, or do hypothesis assessment rather than do hypothesis testing. And usually we need studies that we need to do should be of high quality, because if it is of low quality, this will cause confusion and concerns around patient and clinicians, which that's something we don't actually need just now. So when we do our pharmacoepi studies, in order to have them of high quality, we need to consider the key challenges around the population and outcome definitions, the point that we have mentioned. Also, when we want to publish any findings, we need to adhere to the existing guidelines on how to conduct and report pharmacoepi studies. So we need to be completely transparent around our reporting our study finding, and so the results are reliable and valid. And also, the very important thing is, whenever we read any research article, we always need to think, is this a true association, or it can be due to chance or bias? So always keep that in your mind when you read any research paper. And finally, I would like to highlight this key reference has been published in the PDS, which talks in more detail around, I think, 9 or 8 considerations with examples and details that researchers need to pay attention to when they conduct pharmacoepi studies in around COVID-19, and that includes things I've mentioned, also additional consideration. So by this, I'm ending my presentation, and I will hand over to Sylvia. Thank you.
Thank you so much, Dr. Amanj Kurdi, for that presentation. I want to thank you sincerely, especially for the details of study designs that you've just presented in a very simple. This is truly continuous professional development or continuous medical education. And I think this will be very useful for some of the people that are attending, that are really interested in carrying out research or studies, whether it is just part of their professional development or whether they are also engaging in other studies out there. And I think I've also just want to take note on your emphasis on high quality study designs. I want to remind the participants that please post your questions in the Q&A tab, so that at the end of the 2 presentations, we can take on your questions. At this point, I want to invite Dr. Brian Godman to do his presentation. Dr. Brian Godman.
Okay, thank you very much, Michael. Good morning, ladies and gentlemen. So I'd like to build on what Aman just said, and particularly look at some of the unintended consequences associated with COVID-19. So that slide has just said who I am, and Sylvia's already said that. So go on to the introduction. Next slide, please. This is just me. So again, Sylvia talks a bit about what I've done, so I won't go into it. Just to say, right at the bottom, you can see, or you could see in the last, some of the African countries that I've been working with in the last few years. So hopefully bring some of that into play today. Next slide, please. So Sylvia said, one interest in Africa grew in 2015, where following the World Congress on Pharmacy and Pharmacology in South Africa in 2014, together with a group of people, including Margaret DeLuca, we decided that we needed to form a Pan-African drug utilization group, because none existed at that stage across Africa, nothing with the WHO or others. So this is what we did, and we called ourselves the Muria group that Sylvia's just mentioned. And our first annual meeting of education and symposia was in Botswana later that year in 2015. And we've been holding one ever since then, to really stimulate collaborative and drug utilization research across Africa. So Manj has been part of that in recent years. So next slide, please. So this is where we met in 2016. This is in Botswana, and I think Margaret, Anastasia, and others are part of that. I tried to look out for them earlier on, but the slide was too small. The reason also I mentioned Muria is that this year we were due to meet in Ghana, but that didn't take place. So what we've decided to do, in fact, the email has just gone out this morning, is to hold a virtual conference on the 13th and 14th of October. That will be a virtual conference between 9 o'clock and 1 o'clock GMT on each day. So just gone out, and I think probably Sylvia, Anastasia, and Margaret and others will have the details. It's just gone out, the abstract forms and details. So hopefully we'll be able to include a number of abstracts from Kenya in that and discuss further in October. So hopefully some of you will be able to take part in that virtual conference. Next slide, please. So really what I'll start to do here is talk generally about COVID-19 and then move on to look at specifically infectious and non-infectious diseases. So one of our first activities across Africa really was trying to get a handle on what is happening across Africa, why Africa, and also particularly what some of the unintended consequences are. So as you can see here, we included a fair number of African countries. Within that, obviously, had Margaret, Luca, Anastasia, and Sylvia. So the first proof came out 2 days ago, which is why you can only see this on the slide here. So we'll get our second proof soon, and when we've answered a lot of the questions, so we'll send that out via Sylvia, and then hopefully get published in the next week or so. So next slide, please. So the thing that struck me as we started to put this together was really trying to get a handle on the epidemiology. So this is only up to the end of June. Obviously, there have been more cases since then across Africa. But if we look at the number of deaths, then at that stage, we could see some African countries that really introduced lockdown early on, like Namibia and Botswana, and also to some extent Ghana and Rwanda and Uganda really have very little cases. So that just showed really the impact of lockdown early through obviously previous experiences with HIV, TB and malaria. And if I look at those number of deaths up to the end of June, obviously it's more since then, particularly in South Africa, then really they were less than the whole of the United Kingdom put together. So that to me was an interesting statistic. Along with that, obviously lockdown had an impact, but we're still not sure about the genetic situation. The reason I say that is in the United Kingdom, if you look where the highest death rate is, it's really amongst the Black and Asian community. So particularly Black Afro-Caribbean population in the UK really had quite high mortality and morbidity from COVID-19. So why do we see that in the UK, but we haven't seen that in Africa? So I think as we come out, we'll get to know more about the disease, and then obviously questions like that will start to be answered. So that's partly why we put this together. The other thing that which we did, and we've already had a question on Q&A, and I'll come up to it, is really what about the different treatments? So Manj obviously just talked about what about the ACE inhibitors and ARB situation. We see exactly the same with hydroxychloroquine, remdesivir, lopinavir, etc., and dexamethasone. So the only two treatments that really have been shown to work so far, but we're still sort of exploring them further, is dexamethasone. So that was part of the UK study, and also remdesivir, particularly as part of the US study, and also as part of the UK study. When the early studies for remdesivir, when they came out of China, showed it really didn't have that much an effect. But what we learned was actually that the studies were only a small number of patients, and really they weren't powered that greatly. So the more recent studies have started to show an impact. So again, that's what shows that when you start to recommend treatments out, that we should wait for the evidence to come in and not be overhyped as we did with hydroxychloroquine. Next slide, please. Reason I say that, so this is some work we just submitted for Nigeria, and we've done the same in Kenya, is what I wanted to know is when all this hype came out, particularly with hydroxychloroquine and with antibiotics such as azithromycin and analgesics, and what was happening really with their prices and their utilization. So this is some work we did amongst the pharmacists in Nigeria, looking at changes from the beginning of March to the end of May. Some that we were able to get some quite detailed data, some of them with just impressions. This is sort of things that we found out. So this was in Nigeria with 30 pharmacists. And as you can see, there was really some appreciable impact in the utilization of antimalarials, following all the hype. Why that's of particular interest? Firstly, because we'll see later on that leads to increased prices, and that's an issue if you've got a country with high rates of co-payment. But also in Nigeria, we started to see deaths from cardiac complications and things like that. So again, that shows the value of waiting till more positive data or sort of more data comes out before we start to recommend treatments. So I think that, to me, that's one of the big issues that come out with COVID-19, and we've seen the hype around ACE inhibitors, ARBs that the manager just talked about. Really, evidence-based medicine is critical in this area. We see also, obviously, immune boosters and vitamins, that their utilization has grown. And we've already had a comment on the chat about zinc sulfate. So that comes out as part of this, that we're beginning to see utilization of vitamin C, etc., grow and zinc grow. So maybe we can have a discussion around that as we go forward, because again, this will impact on areas such as co-payment and affordability. Next slide, please. So this is just, when I talk about affordability, this is just some of the price increases that we've seen for antimalarials and antibiotics and vitamins, etc., in Nigeria. So again, this is critical from a patient point of view, particularly if they're high co-payments and issues with affordability, and also from pharmacists' point of view is how we can better control our stocks so that we can try and moderate some of these price increases to the benefit of our patients where they're needed. Next slide, please. One of the interesting things for me, and this came out, obviously, the work that we're looking to submit probably tomorrow, but also some earlier work we did with Sylvia and others in Kenya, is that when you have qualified pharmacists working in pharmacies in Kenya, then there is limited or no self-purchasing of antibiotics. So that when patients did come in with sort of upper respiratory tract infections, they were sort of more targeted towards what more appropriate sort of treatments for a viral infection rather than antibiotics. We've seen very different situations in some of the other African countries, such as Zambia, where I've worked, where up to 100% of pharmacists were self-dispensing, so allowing patients to self-purchase antibiotics, and some of the other countries that I worked in. So this showed to me that when we have trained pharmacists working in pharmacies within Kenya, then and basically we were able to limit the extent of self-purchasing of antibiotics. And that was, we also saw that with the COVID-19 situation, where although there was increased requests, there wasn't increased dispensing for these and also antimalarials. So for me, that was interesting to show that where we do have good pharmacists working in pharmacy shops in Kenya, then we're able to enhance the appropriate use of antibiotics and antimalarials. So to me, that was an important message going forward, and maybe we can talk a bit about that a bit later on. Next slide, please. So that was a little bit about COVID-19, and no doubt we'll talk a bit about more in the chat show. So anyway, as far as infectious diseases are concerned, what again struck me with COVID-19 is really the unintended consequences. So if we look at malaria, then really, because patients aren't getting the nets and not getting the communication or the treatments, then we'll probably see many more deaths from malaria than we will do from COVID-19. So I think that's something we should look at. Even more important is the fact that our children are not getting immunized. So again, the predictions are that if this continues, then again, we'll probably see more deaths from measles and diphtheria and things like that than we will see from COVID-19. So I think when we talk about in the future how we manage pandemics, yes, because COVID is very transmittable and you can stop that transmission by stopping direct contact with patients, then there was an imperative to test and lockdown early on. But what has been the consequences of that? And that's something we also need to look at a bit further. The same with HIV. I'm not sure that there's much association between if you have HIV, you get increased chances of COVID. I think that that's not really shown. But what is important is that HIV patients might say, okay, I'm not going to the clinic because I'm going to get COVID-19, and therefore I'm going to stay away. The clinics aren't taking place because they've been shut down. Are the patients getting their medicines? Are they adhering to the medicines? So again, in infectious diseases, it's the unintended consequences that I think we've got to look at more. So what's happening to malaria? What's happening to the childhood mortality as a result of not getting immunized? What's happening to HIV? Are the patients getting diagnosed? Maybe less so now because of the lockdown measures. Are they getting all their treatments? Yes or no? Are they adhering to their treatments? Yes or no? So that's something I think we should look at in Kenya as we go forward with your help. Also around what sort of programs to improve antibiotic utilization. As I said earlier, we've seen a lot of overuse of antibiotics for upper respiratory tracts in the community. In the hospitals, we see overuse as well, or not appropriate use. So again, what are we doing around that to make sure that we reduce our resistance rates, which are high in Kenya, and we need to reduce them? So again, it's what research can we move forward in this area to help us? And certainly, I think if we look at malaria, if we look at COVID, if we look at vaccines and things like that, then there's a real role for the pharmacists here, not only to give out appropriate messages about prevention of COVID-19, sanitization and social distancing and masks and things like that, but also they can help with vaccinations that we've seen in other countries, and they can also help with really enhancing adherence to medicines for patients with HIV and things like that. So to me, there's a increasing role for the pharmacists as we move forward to help to reduce the unintended consequences of COVID. So I think that to me is some of the activities that will come out from COVID-19 is how can we use community pharmacists more and maybe different techniques. So what about telemedicine and things like that as a way forward? And so maybe we can discuss that further in the Q&A. Next slide, please. And also carrying out with our research. So if we're looking at antibiotics, then again, we need to know in hospitals, really, well, what are we using our antibiotics well? What are we using them for? Do we always have an indication for the antibiotic use in the hospital? Do we have a situation after 2 days where we will monitor the use and maybe change the use? What about IV to oral? All of those activities should be taking place within hospitals at the moment, even with the COVID-19 situation, because we don't want to stop the momentum regarding appropriate use of antibiotics. We want to make sure in hospitals that we are using them well to reduce the resistance rate. So these are just two of the recent studies that we published with Silver and others, just to show we need to sort of keep that going. Next slide, please. So that was very quickly around infectious diseases, and more will come out obviously during the Q&A. So now on to non-communicable diseases. To me, and it was really a shock, and maybe it shouldn't be a shock, that really the rate of hypertension in sub-Saharan Africa is much higher than we see in some of the Western countries, particularly some of the Western European countries. So we need to be able to manage that well. And we've shown with previous work we've done with Silver and others in Kenya that really we can help with adherence to guidelines and things like that by educating the patients and helping the patients. But a real issue across Africa really is, well, what about availability? And that's obviously a big issue in Kenya if there's high patient co-payments. Obviously the access programs can help a bit there, and so we need to monitor those. But okay, if they get their medicine, are they adhering to the medicine? Because again, we know that's a real issue across Africa. So what can we do there? And obviously there's a role for the pharmacists in Kenya to help with that, to help in the primary healthcare centers, to help in the community pharmacists, etc., and maybe instigate use of diaries and things like that to really help. So I think that's an activity that we can do even more so now, because where are patients going to collect their medicines? Well, increasingly in the pharmacists. So I think there's a role for you there to help with adherence as we go forward, particularly because of the high morbidity and mortality that we now see from coronary vascular disease across Africa, including Kenya. And obviously, as part of that, diabetes is a big issue as well, and obviously not only for controlling your diabetes, but also helping to prevent some of the coronary vascular disease. And we saw that as, again, like adherence, as a big problem across sub-Saharan Africa. Next slide, please. And the reason I go on about adherence, because again, we see that is a big issue, even in Namibia, which is a country that's got universal healthcare system. And we saw that really the patients had problems with adherence. One of the issues with that is that they really, although they got free healthcare within the primary healthcare center and their medicines were provided free, if they had to take significant time off work to go to the clinic, and they didn't necessarily have a family support system, then their adherence was poor. So again, that suggests me a role for yourselves going forward to help with that. And we certainly saw that in South Africa with some work that we recently published there. Next slide, please. So this is our paper on type 2 diabetes, where we looked across Africa as to what were the rates of type 2 diabetes, what were the countries doing to try and improve the situation, and what were the lessons going forward, including with community pharmacies. So you see there, Margaret and Anastasia are part of that. So that paper is now freely available. And we did similarly for type 1 diabetes as well. So I'll send that to Sylvia to send that to you. Next slide, please. So I think going on, really, I think there are roles for yourselves, I think significant roles for yourselves that COVID-19 has really accelerated. So really, from non-communicable diseases, help with diagnosing in pharmacies. So really around issues such as blood pressure monitoring and things like that. Help with medicine availability. We know that's an issue, that can be an issue in primary healthcare centers, particularly if there are problems with supply and the supply chain. I think that's something that we can do about, we can help with in community pharmacy. Help with potential prices, so help with good stock control and things like that to help to moderate those. We saw within that situation in Nigeria just what price hikes there have been very quickly around antimalarials and antibiotics. I think better stock control can help do that going forward. And I know that there are moves within the East African community, so within Kenya, Uganda, etc., to look and see, can we do more about local production? So can we be less reliant on India and China with our raw materials and some of our finished goods? Can we look to produce more locally so that we can reduce, if you like, reliance on long supply chains and help our patients? So maybe again, that's something we can talk about. And last, I say help with key issues regarding adherence to medicines, particularly for chronic diseases, looking at, say, talk about telemedicine and other approaches that we can use in the future. Next slide, please. And this is just a paper that we did in South Africa recently, again, looking at knowledge about patients with type 2 diabetes in community healthcare centers and what we can do about it. So I think that's something that we can, I'll send again to Sylvia afterwards for distribution. So I think to me that suggests a key role for yourselves going forward. Next slide, please. So just in summary and conclusions, I think for me, what COVID-19 has really shown is two things or three things. Firstly, the unintended consequences. So what are the unintended consequences around other infectious diseases and non-communicable diseases? So we need to know more about those unintended consequences. So I gave you some flavor of that, but we've got obviously more about that in our COVID-19 Pan-African paper. But really we need to know more about that across Africa and including Kenya, so that we can better plan for these pandemics going forward. Also for me, coming forward, there's a key role for yourselves. And I don't think that's been emphasized enough in the literature, and we've put more about that out now, really regarding the key role for pharmacists going forward, not only in prevention, so what you can do educating patients about how they can prevent these transmissible diseases, around sanitation, around social distancing, etc., but also really provide evidence-based advice. So we saw with Nigeria, and we've seen in other African and Asian countries, the hype surrounding hydroxychloroquine and what are the consequences of that. And similar with antibiotics. So again, you yourselves can help with that, and certainly with antibiotics, with teasing out what's a viral infection or helping to tease out what's a viral infection versus what's a bacterial infection. So again, helping to use more appropriate antibiotics, and we started to show that that is happening in Kenya. We want to move that forward. As I said, and then also helping with immunization programs. So again, can we get a more of a role for pharmacists helping with that? We've obviously, and talking now more northern countries, we've got the flu pandemic coming on in Europe soon. So the last thing we want is a flu pandemic alongside any second wave of COVID. So I think we're already seeing in a number of countries that pharmacists can give flu vaccinations. So let's get an increased role for all community pharmacists going forward. Obviously need to be appropriately trained, because if they're not able to get to the primary healthcare center to get their vaccination, then that's going to have a real impact. And we've seen what sort of high levels of morbidity and mortality already being talked about if children are not getting immunized. And as I say, we see the same with the flu vaccination. So let's get a role for yourselves to get more routinely involved in that going forward. There's no reason why you can't get more involved in that. And last, as I say, if non-communicable diseases are really growing, and we know that the COVID will accelerate increases in coronary vascular disease, increases in diabetes, type 2 diabetes, increases in cancer, because we're just not getting the diagnosis and patients aren't getting the full course of their medicines and aren't adhering to the medicines, then this is really storing up problems for the future. And I think in both other infectious diseases and non-communicable diseases, far more people will die from those as a result of what's happening with lockdown with COVID than will actually probably die with COVID. So to me, that we need to move all of that forward, and there's a key role for yourselves to really document the unintended consequences of COVID-19 to help us to better plan for the future, and with it, to see an increased role for community pharmacists in Kenya and wider. Next slide, please. Next, so that's it. Yeah, so that's all I've got to say. So these are some of my email addresses. Probably not use the KI so much, more the Strathclyde and the Outlook. So hopefully that's laid a foundation for some of our discussions as we move forward later this morning and post this session. So thank you.
Thank you very much, Dr. Brian Godman, for that presentation. And again, thank you, Dr. Munch. Participants, I encourage you again to keep sending your questions through the Q&A tab. And I'll just jump in straight to questions there. There's Joseph Esekon, who says, during your study to establish association between the use of ARBs and angiotensin-converting enzyme inhibitors and hospitalization of COVID-19 cases, did you consider the response or its effects on different races in the different regions? I think this is to Dr. Amanj.
Yeah, okay, so thanks, Joseph. So the study I've presented, these are kind of confidential results under reviews, or it's a meta-analysis of studies. So regional variation and differences in the region for the different criteria for hospitalization is a factor, but that's not the only reason I explained the differences. So as you said, the race, ethnicity, between Chinese and American, European, there are maybe explain difference. So although there is some evidence around that, polymorphism of the Icu enzyme, which is the point of the virus entry into the cell. There's also this kind of some polymorphism playing a role. So I'm not saying that the region variation could be only because of difference in the criteria for admission or the testing threshold. That's maybe a factor, but there are also other factors. So remember, when you do a systematic review, you usually don't have that, or I guess you can do, for example, if the study's individual study provided you with the proportion of ethnicity in each individual study, you can do a subgroup analysis based on the race and ethnicity. But usually that type of data is not available by each individual study. But from the pathophysiology and the biological of the disease of the COVID-19 and our understanding to the virus till now, you know that actually, you know, Asian, Black people are more likely or at risk to poor prognosis compared to white Caucasian people. But yeah, absolutely, race is an important confounder and might explain some of the regional variation. In addition to the mentioned threshold of the testing, but also threshold for hospital admission or ICU admission. So I hope that will answer your question.
Thank you, Dr. Manj, for that. I have a question for Dr. Brian. You highlighted a review on ongoing activities and challenges for the care of patients with type 2 diabetes across Africa and the implications for the future. So maybe you can just shed some light now with the pandemic that is ongoing, some of the anticipated long-term effects of COVID-19 on one, access to these anti-diabetic drugs or diabetic services. Keeping in mind the poor prognosis of, you know, COVID patients who are diabetic at the same time, and maybe also to give us some ideas of the role of the pharmacists in sort of giving direction in anticipated long-term effects of COVID-19 and diabetes type 2.
Okay, thank you for that. That's a very important question. I think the three things that, if you like, what the long-term consequences are is, firstly, are the patients adhering to their lifestyle? Because if they're not being talked to regularly by healthcare professionals, are they going back to using salt in their food? Are they not exercising? What about high-fat diet? Are they moving to a lower-fat diet? I think there's a lot that the pharmacists can do and others around lifestyle modifications. So if they're not getting regular input, are those regressing? Secondly, regarding the medicines, certainly regarding metformin or statins or medicines for hypertension, then again, are they getting access to those medicines? I know in Kenya that Sandoz have an access sort of project at the moment to help with that. So can we ensure that the patients get access to the right sort of medicines? And more importantly, are they actually taking them? Because again, with the work we've done in Kenya and elsewhere, the adherence to these medicines is substandard. So again, the pharmacists can come in to play really to help with this. So not only to make sure the medicines are available, but talk to them about adherence, etc., and maybe even look at sort of blood pressure control and things like that. So if those things are slipping, then what will happen in a few years' time, we'll see an increase in coronary vascular disease, so increase in heart attacks and strokes, etc. We'll see an increase in peripheral vascular disease, so we'll get eye complications and feet complications as well as kidney complications. So for me, that's some of the unintended consequences coming through, and we as pharmacists can help to, as I say, to make sure the patients adhere to lifestyles, because we know that type 2 diabetes can be reversed with appropriate lifestyle and other changes. Are they getting access to their medicines, and are they taking their medicines? Does that help answer the question?
Yes, thank you. Thank you so much for that. Rose Kitawi, this is a question again to Dr. Godman. Would the role of vitamin D be the reason why there were differences in mortality and morbidity in the people of African descent in the UK and patients? Has this been examined?
Thank you for that. To me, that's a really interesting question, because the reason I say that is that vitamin D is we see in some countries, and we've done some work in Pakistan and things like that, that there really is a vitamin D shortage in some of these countries. But have we seen the same mortality rate? That's more difficult. I think, to me, the interesting thing, and this is where we need to look far more at genetics and other factors as we get to know more about COVID-19, is why we've not seen the same impact on morbidity and mortality in Africa as we've seen amongst the, as I say, Black and Asian community in the UK. As I say, there's more deaths in the UK amongst Black and Asian population probably than the whole of Africa, or has been up to fairly recently. So I'm not sure why that is. And I think that's some of the questions coming out as we go forward, is what is the situation in Africa compared to these other countries? Has there been genetic mutations amongst the Black African community, and we see the same in the US versus the UK, versus what we see in those who still resided in Africa? So maybe, as we know more about genetics, we'll need to know. I think vitamin D is interesting, but I'm not sure how relevant that is, except to say that, yes, we want to make sure our patients have immune boosters if that is lacking, because that helps generally with influenza as well. I know there's a comment on zinc as well. So maybe that's something that we can look at, but genetics is going to be a major area going forward as to why we see some appreciable differences across countries in morbidity and mortality rates.
Thank you for that. Dr. Tracy Muraya, I know this question has been answered by Dr. Manj, but I think it would be nice just to share with the rest of the participants. Tracy Muraya said, thank you, Dr. Manj, for the good presentation. Could these differences in patient response to ACE or ARBs in ICU in the different regions, USA versus Europe, mean that the two regions could be dealing with significantly different strains of SARS-CoV-2 virus, in addition to other stated co-founders? Maybe you can just share with the rest.
Yeah, I think with the virology and RNA sequencing, you can, I think, tell if you have a different strain of, so you can easily, I think, determine or exclude the different strain as a cause, because you can usually, I think, easily you can do the RNA sequencing and tell a different strain. And the other thing is, unless the different strains are having significantly different mechanism of, cell entry because the only link that why ACE inhibitor ARB, they are linked with COVID is they are having an impact because the virus used the angiotensin converting enzyme 2 as an entry point. And, these drugs are actually, in a way, indirectly through the loop feedback mechanism may upregulate these receptors. So there's kind of some hypotheses both in favor and against how these drugs can be protective or can be harmful. So unless, even if there are two different strains, but even if the two different strains, they are using the same cell entry point, which is associated with these drugs, that's unlikely that will explain the variation. I would say, as I said, you can easily tell if you have different strain or not by using the RNA sequencing.
I have another question for you again. This is from John Mugumura. We have been told that over 80% of COVID-19 cases in Kenya are asymptomatic. What kind of would tell us why this is so in order to even increase this percentage as part of the possible solutions for COVID-19? I think it's probably also asking what kind of study designs would be best, one, to confirm this, and how useful would that study be in informing its policy?
I think one thing here we need to think of, priority research question that we need to answer given the resource and the pressure on the health system. So I think maybe the key priority question is more kind of to see what kind of patients are at risk of hospitalization or death. And then maybe this one, I think, go back to the communities. I think the only way you can do that is to actually do a wide community-based COVID test screening, okay, and see the, people identify asymptomatic people as a positive PRC test, those versus those who do not have, and then you can see if there's any difference between characteristics or age or any factor which might explain. But I think that's depends again on each country. Is that a priority or not? Because I think there's been studies showing that even a symptomatic patient still can spread the disease. So I think for this, we need to do a more kind of community-based wide screening to identify those asymptomatic patients, because if they have no symptoms, there is no way you can identify them by, through GP practices or hospitals. You have to do a more community-based screening to identify those and do more study closely on their characteristic to see why they are asymptomatic compared to those who are symptomatic.
This is Brian here. I think your figures would probably be, I'm not sure how accurate they are, because my impression is that the asymptomatic patients are a much higher proportion than you just discussed. So I think there is work, and I think we included some in our COVID-19 paper that do look at the rate of asymptomatic patients. I think that's been one of the key problems or key challenges with this disease, is because we just do not know the rate, as Aman just said. Our rate of testing generally across most countries has been suboptimal, and we generally only test if we suspect as well. So it has been quite problematic. So I would suspect the rate of asymptomatic patients would be much higher than just stated.
Thank you for that. Dr. Brian, I have, again, given the increased access to medicines online and the current situation with the pandemic, COVID-19, patients are becoming more skeptical going to retail pharmacies or community pharmacies. How do we ensure and keep on improving pharmacy practice using telemedicine or telepharmacy with COVID-19 and its effect?
I think that's a really good question. I think some of the legislation around self-purchasing in pharmacies online, that needs to be tightened, because we just do not know the quality of those. And I think in Africa, there's been something like the LOMI initiative to look at the rate of falsified medicines, which we've known have increased as part of the pandemic, particularly hydroxychloroquine. So I think that's one of the issues there, is what can we do around online ordering to help to improve the quality of the medicines dispensed. And to me, that emphasizes a role for community pharmacists going forward, because we know that if patients get their medicines online, how do they know when to take them? In particular, if they're on multiple medicines, as somebody with type 2 diabetes, particularly if they've got type 2 diabetes and HIV will be on, so they don't know when to take them, why they're taking them, and what adverse reactions to look out for. And again, with yourselves, to help monitor them regularly with blood pressure and things like that, and just generally help them with counselling. So to me, that's a role for the pharmacist going forward that can be communicated. So I see your role as increasing, if you like, and telemedicine helping with that, to say, look, we know as part of the pandemic that, okay, we can maybe do online to get medicines to patients, but do they know when to take them? Do they know adverse reactions, etc.? So I see that's a key role for yourselves going forward, as to help with these issues. So by documenting these issues and looking for proactive ways forward, to me, that enhances the role of the community pharmacist against just mail order, if you like.
All right. Now that you mentioned hydroxychloroquine, Dr. Yvonne Kamau would like you to comment on the current myriad of information surrounding hydroxychloroquine and its benefit to COVID-19, including the suggestion that it still could be effective for pre-exposure prophylaxis by the COP-COV trial?
Okay, that's a very interesting question. I would say that if you look, this is for treatment. I'll start off with for treatment before I get on to prevention. So if you look at treatment, yes, there was a lot of hype with the initial studies, particularly the study coming out of France from Marseille. So that led to Trump and others sort of promoting it. But if you look at the UK study, and if you look at some of the other studies that have come out, then both the WHO and the NIH have dropped hydroxychloroquine from their studies. So that tells you everything you want to know about it. And also there've been studies on prevention now in the New England Journal of Medicine that have shown no real benefit. I'm aware of a study in India, and I think we've quoted on it, that showed that it might have a role in prevention for COVID-19, but that's one of the only few studies I know. Most of the studies now are saying there's got no real benefit. And as I say, both the WHO and the NIH have dropped hydroxychloroquine from their arms of their studies. So I think that and the same with the UK. So I think that tells you all that you want to know about the role of this medicine. On the other hand, as I said earlier, we've now got positive studies from dexamethasone and positive studies from remdesivir. So we need to look at those more as we go forward.
Yeah, thank you for that. I think there's quite a lot of work to be done around medicines or concerning COVID-19. Maybe I'd like to just ask both of you to give a comment on the speed of vaccine development following COVID-19 and what you think is going to be the impact on drug development, not necessarily just vaccine or just generally drug development, because it seems like there might be a trend developing. Maybe I can start with Dr. Manj.
Yeah, thank you. So I think that's the Oxford vaccines is promising, and now we have, I think, a few vaccines in phase 3 clinical trials. So hopefully, in the next few months, we might have some information on the efficacy of those vaccines. I think in terms of drug discovery and drug development, I think we still don't know much about the COVID-19 in terms of how, the virology and the pathogenicity of it. So I think that's maybe still an earlier stage to have a drug targeting the COVID-19 in particular. As Brian said, that we see some other already available antiviral are shown promising results in the recovery clinical trial, and so I think that's all. I think is good news for now.
Yeah, I think certainly there's a lot of work going on, as you say, about COVID-19 and vaccines, as the manager's been saying, and hopefully with the amount of those being developed, then at least some of them will start to be effective in reducing the morbidity and mortality. Whether we can get to a truly effective vaccine the first time off, I don't know, but certainly vaccines that can help to reduce the morbidity and mortality will be welcome. As far as research in other disease areas, that will continue, and certainly around cancer and orphan diseases. And now, unfortunately, the two main ones being researched at the moment, mainly because of the high prices that companies can get in the higher income countries. So I see no slowdown in those being developed, as I say, just because of the high prices, and that will continue. Let's say COVID-19, yes, a lot of work's going on at the moment, and that will continue, but along with, I say, looking at cancer and orphan diseases. Unfortunately, limited work in antibiotics, and so we're looking at new models for there. What about almost a model where we just delinkage, so we pay companies for developing a new antibiotics and delinking that from sales. So that's some of the models being looked at for there, because unfortunately antibiotic research has suffered in recent years. I think HIV is still continuing, but as I say, most of the efforts from the major companies are in cancer and orphan diseases, apart from just quickly looking at vaccines.
Thank you. Just one last comment from Dr. Brian. I know you have on quality of prescribing in part of your work. And we are well aware that azithromycin is one of the antibiotics that is being prescribed for the management of COVID-19 patients. How can the prescribing of these antibiotics be improved quality, given that AMR is also just around the corner?
I think that's an important question. I think certainly with azithromycin is more being linked with hydroxychloroquine. So I think from that point of view, that there's no rationale for giving it in COVID-19 patients at the moment. So really it's more around, is it viral, is it bacterial? And it can be quite tricky in COVID-19 patients. I think that's where, as we get increased testing, that will help us better with a differential diagnosis. So I think as we move forward and we get to know, tests now being developed that can help us to know within 10 or 15 minutes whether a patient's got COVID-19 or not. So as we get more rapid point of care testing, then I think that will help us in the first instance. I think from community pharmacists, we can say, well, if you are worried, are there opportunities to get tested into various testing centers to rule out COVID? Because if we are concerned that it's not bacterial, it's more viral infection, then we shouldn't be giving antibiotics in the first place, just because of the risk of AMR. And I know in Kenya you've been good at that, certainly where you have trained pharmacists within the pharmacy shops. So I'll carry on with that, and really it's to help improve the diagnosis and help improve the management of the patient accordingly.
Thank you very much, Dr. Amanj Kurdi and Dr. Brian Godman from Strathclyde Institute of Pharmacy and Biomedical Sciences, University of Strathclyde, Glasgow, UK, for sharing with us and being with us this morning just to talk about COVID-19 and the role of the pharmaceutical sector. I also want to appreciate the presence of all the participants who are able to take time today, over 400 participants. The different cadres, pharmaceutical technologists and nurses and all the other cadres that are here, including my own colleagues and pharmacists. I also want to appreciate everybody who put together this webinar. That is my co-moderator, Dr. Sylvia Opanga, Dr. Eric Muringu, and the CEO of the Pharmaceutical Society of Kenya, Dr. Daniela Munene, Mbao Gitau, who has done a very good job in terms of making sure that everybody knows about these webinars. This, again, is an ongoing series of webinars where we share, and this is part of the Pharmaceutical Society COVID-19 Response Task Force. I want to pass on the mic back to Daniela Munene to close this webinar. Thank you.
Thank you, Mike. That was an excellent discussion. I saw so many studies being referred to, so my request to Dr. Amanj and Dr. Godman, if you could kindly share with us any studies that are shareable, we will disseminate them to our members for further in-depth reading. Okay, so I would again wish to thank our moderators and our distinguished speakers and my colleagues at the Secretariat, and thank you participants for joining us until the end of this session. Our next COVID-19 Dialogues webinar next Wednesday will be on pharmacovigilance in the era of COVID-19. So please look out for the poster and join us at the same time next week. From all of us here at PSK, it's a good day to you all. Thank you. Goodbye.
Goodbye.
Okay. Thank you, everyone.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye.
Bye.